All right. Good morning. First of all, thank you all for joining. And I would like to thank Dr. Graham. Joseph will be joining. He's on call today. I want to thank Ravi, Roy, Selvi, Sylvia, Sriram, and Dr. Stroline. And these are my acknowledgements. I want to thank John Stroline for his support, Mr. Charles Butt, and Ms. Angela Dio. So we'll try and see if we can, I want to get into the habit of incorporating this poll. This is completely anonymous. You may want to take your phone or something and put, go to Google and put poll EV dash GSR. pollev.com backslash GSR 977. And if you just agree, and you can actually just say where were you born, just for the sake of interest.
I don't have one of those phones, but I was born in Panama.
One thing I've realized is PolyV works well, but it slows down the process. So the question is, people need to have a little bit of patience to do this. Okay. Everybody has their PolyV on their computer, on their phone or cell phone or computer. So, yes. All right. So this is the story of a 60-year-old, and I'm going to share with you his story. You know, he came in for surveillance colonoscopy, and this was a video that was recorded in 2019. He has a family history of colon cancer. Father developed colon cancer at age 70. And in 2011, he had 2 serrated adenomas. 2015, 2 tubular adenomas, and then 2019 colonoscopy. So with this story, why don't I stop and let Selvi comment on, you know, when you see the story of somebody with a family history of colon cancer at 70, how do you address that?
Hi, Raju. Thank you. So I'm glad that you got the family history. I think many people neglect to do that, and I think it's important. It's important to ask about a family history of colon cancer. It's also important to ask about other types of cancers within the family. So this patient has a first-degree relative who developed colon cancer over the age of 50. So that increases the risk slightly, but not significantly. I think more important is their past history of personal history of colon polyps.
Okay. One other thing is we also need to keep in mind, as we see patients periodically, we should go back and ask the family history again. And that is important, because if you start somebody, you know, with the current recommendation, start colonoscopy at 45 for average risk, and you say to them, you're good for 10 years. And but I don't really say you're good for 10 years. I tell them that 5 years down the road, you reevaluate your risk. If the family history changes, then your risk changes. And I've been doing that for maybe several years. And I found 2 patients where they came back and said 5 years down the road, they had a family member with colon cancer. Sylvia, what are your thoughts on that?
Um, I very much agree with Selvis' comment. According to European guidelines, one first degree relative with colorectal cancer older than 50 means that the risk is very, very slightly increased, not significantly. He would not fulfill the criteria for familial colorectal cancer, which would require at least one first degree age under 50 or two first degree relatives any age. So I very much agree with Salvi that most relevant in this case is his personal history of colorectal polyps.
Okay, that's good. So I'm going to show you the examination of the right colon as I go to the cecum. And let Zubair comment on this. Zubair, what are your thoughts as you see this cecal examination?
Well, so far it looks normal.
Okay.
I don't see anything like unusual here.
Okay, that sounds good. Selvi, how about you comment on, you did a study looking at people reaching the cecum and documenting it. What is it that we all should do in terms of documenting the cecum?
So one of the quality indicators in the US for screening colonoscopy is greater than 95 or 97% of the time. When you do a screening colonoscopy, you reach the cecum. And I think it's important to do photo documentation of the cecum. So some possible things that people should consider doing photo documentation of is the appendiceal orifice. It's also important to examine the floor of the cecum. It's important to do, apart from photo documentation, a good circumferential view of the cecum. It's also important to look behind the ileocecal valve. Another photo documentation would be the ileocecal valve to include in your report. And lastly, if you're able to routinely get into the habit of intubating the terminal ileum, putting some water in there to make the villi show up better and doing a picture there, I think that is a great way to photo document a complete exam to the cecum.
Yeah, beautiful.
I also routinely examine the cecum both under white light and under NBI, because it is difficult to miss subtle lesions, especially in the floor of the cecum and within the appendiceal os itself.
Yeah.
Thank you.
Beautifully said. So the fellow should keep in mind to take at least 3 photographs, minimum, not necessarily limit to 3, to look at the cecum, show the ileocecal valve, and also show the TI to make sure that you have examined the cecum, documented that you reached the cecum. All right. So let's see if you want to, what do you see here? Do you see anything at all? Or do we go by what Zubair says? All right.
Are you able to go back, Raju, and show the picture so people can look at it?
I'm going to show again one more time. Okay. You want me to do that? Okay, let's do that. Maybe I should put what Selvi has mentioned, that I did not show the area between the ileocecal valve, the slope that goes to the cecum. So you could actually, maybe I should have put it in the quiz.
Mm-hmm.
All right. You guys agree with that?
Yes.
Okay. All right. I'm going to show you this thing again. Okay, so let me go back. I think I'm glad that Selvi made a comment. That's good. We'll look at it again so that all right. All right. Everybody has voted. Shall we? All right. Do you think AI would have helped here, Selvi?
I think NBI would have helped, Raju. That is
Yeah, you certainly
that is that is
taught me a lesson,
that
Mark.
is technology that's available on every scope. We should not rely on artificial intelligence. We have our own eyes and we have high definition scopes with NBI. So I would turn on NBI.
Yeah, first of all, I need to share this with everybody. At one time, I was struggling, and then I said, I'm not sure I'm seeing something. I'm not sure. And then I asked Selvi to come into the room, and she said, why didn't you turn on NBI? And I'm glad that she told me and taught me a good lesson. Anyhow, thank you, Selvi. All right. Okay, let's look at this.
Mhm.
Beautiful. Mhm.
All right, Sylvia, do you want to comment on that?
I think that I will still go for normal image. At 3 o'clock, I had the idea there is a subtle change, but I'm not sure it's relevant. I think I would go. Well, now it's better to. So the contour of the fold is interrupted at 3 or 4 o'clock, and now I see a whole lesion. Yes, that's much better. Yes, and there. Yes, it's a
So
very.
actually,
I
okay,
fully agree that this is a very subtle flat lesion.
right. So let's see, let's play it again. I want to show something that I want. Uh, let's see, I need to get out of that. Okay. I want to show something and I want Zubair to think about it. And that is when you, one of the things is, although the appendix looked good, and I would have, few years back, I would have been happy with this exam and said I reached the Cecum and everything went well. And if you actually present this picture, I think like all of you agreed, it's a normal Cecum. And but a few years ago, I incidentally saw a lesion into the appendix at the mouth of the appendix. We think that this is the appendix orifice. Probably this is just an overhanging fold that is obliterating or covering the appendix orifice. And by putting a cap and then going and stretching this, and as I go very close, you will notice that I don't put any more air, but I press on the air water button to just let a little bit of water come out. And that will actually take away the air, the interference, and actually it will give you a better picture. I want you to notice that. So we go down, and this is an uninterrupted, unedited video of the segment. So we try to open, and I thought that I saw something. I was not sure. Whether it's, so I started putting water there. You see that? And the water would allow me, and then I put NBI, and then I used the near focus. And that near focus allowed me to feel confident that there is something there at the mouth. And that is something to keep in mind. I think I want to play this video one more time for the sake of the trainees to appreciate. And so we go back and gently press the overhanging fold, and you see something, and then put in a little bit of water by pressing the air water button, not the water jet. Change it to NBI, change it to near focus if you have an endoscope. That will help you define the lesion a little bit better. And you can see a lot better that you have something there. I think that's very important to keep in mind. And what I was trying to do is I'm trying to define the lower edge. The lower edge of this lesion has actually gone deep into the appendix, and I cannot define the lower border. When I can't define the lower border, that's one thing that I cannot resect. And if I can define the lower border, about 6 months back, I took care of a physician colleague where I saw a lesion, but I could define the lower border completely, and we were able to just remove that easily.
Mhm.
So we went ahead. Go ahead.
May I ask a quick question? Based on the macroscopic appearance, what would be your diagnosis of this lesion?
I felt that I was dealing with a serrated lesion.
Yes.
And sometimes what happens is when we do the prep, we typically give bisacodyl to clean out the colon. And sometimes the bisacodyl can cause edema. But when you see edema of the mucosa, you still see the round pit pattern. Only thing is the pit pattern is a little bit bigger because of the edema and stretching. But here you see a different type of pit pattern than a normal one. And let me see, right? You can see that there, right? You can see that pit pattern, which is a little bit different from the previous one. So we went ahead and took biopsies. I wanted to make sure that this was truly a serrated adenoma. And without those biopsies, you don't want to just jump and send a patient for surgery. So as I can see this, one of the things I do is when I'm taking a biopsy, I try to pull that thing out and not necessarily take a biopsy and pulling it out and trying to see if I could define the lower border. And if I could define the lower border, I will still try and see if I can remove that during the procedure. Here I cannot, the lower border keeps on extending into the lumen of the appendix. And once I confirmed that that's the case, I went ahead and took biopsies. So we took maybe 2 or 3 biopsies, and
Raju,
yes, Sylvie.
did you think about maybe trying to do an injection to see if you could try to evert at least part of the appendix?
Yeah.
to better visualize the lesion?
Right. So what goes in my mind when I see something at the mouth of the appendix, like the way we saw, is as you mentioned, okay, is this something you could remove? And the first question I ask myself is, could I define the border that is going into the appendix? If I can define the border going to the appendix, I inject and try to remove it. If it is not, if the lower border that is going into the appendix could not be defined for sure, then what I do is I try to pull it out, like I've pulled it out without taking a biopsy piece and see by pulling it out, could I still define the border? And if I fail that, then I say this is not something I could resect. The other thing that I want to also share is the appendicular orifice opening doesn't have that much of submucosal cushion to allow you to give a good lift. It works at the rim of the appendix, but once you go just inside, I've not had much success when I was trying to inject to lift, you know. Appendix wall is a little bit different from the colon wall. Yeah. So the for the sake of fellows, I want to share with you, when you see an unusual finding, you know, it's very important to document, especially if you think that a patient would require another intervention. In this case, my thought process was, this is looks like a serrated adenoma. If the pathology confirms it is serrated adenoma and it is extending into the appendix, that is not amenable to endoscopic resection. I want to convince the surgeon that he should go ahead and do the surgery to remove the appendix, including the base of the appendix with a little bit of cecal ring. And in order to help the surgeon feel comfortable that he's not operating for nothing, you have to take a lot of pictures. And this is what I normally do, and I hope this will help you. So, you know, this is the complete pictures of this patient. Patient had a rectosigmoid polyp that was cut, and you'll forget about that. And this is the appendix orifice. And the way I do is appendicular orifice polyp images from 6 to 25. So that's how I mentioned at the beginning, so that when they're looking at the images, they know that all these images are of one particular area of interest. So as you can see here, I also take images, keeping in mind that, you know, we want to educate others. And if you want to educate others, you can only educate if you have a large repository of images. So you can actually show this image to somebody and say, hey, does it look normal, or here normal? And as you can see how we define that polyp in different ways, so that whoever is looking at it is convinced that there is truly something that needs to be addressed. So I just wanted to make that point, right? Get into the habit of taking a lot of images to help your colleague feel comfortable and make the right decision. Ravi, any thoughts?
Interesting case, but yeah, the lesion looks very subtle unless we pay specific attention to the appendix in greater detail. This lesion could be easily missed, I must say. The one other question which I had was, when we see such lesions, what would be your preference to send to surgery? Because this looks benign. If it's, for instance, if we detect this lesion in, say, a patient who is 70 years old compared to a patient who is like 40 years old, would your approach differ?
You know, the thing is, 70-year-old guy, if he lives to 90, right? Or 70-year-old who lives to 75, right? Whatever. Or, if you're going to live for 75, you shouldn't be doing the colonoscopy. But, two things. One is if I see a lesion, I always say to myself, is there something going beyond? And doing a laparoscopic appendix removal is like a day surgery, right? We always count everything like a big deal. Unless the guy has so many other comorbid conditions that would limit. I've seen at least half a dozen of these types of cases in the last 5 to 7 years, when I made it a point to examine it. Every time I go to the Cecum, I don't take a long shot and say, hey, I reached the Cecum. I tell my team that we need to go and look at the opening of the appendix or kiss the appendix opening to actually have a good look. I've seen a few actually serrated adenomas, including a serrated adenoma in a colleague of mine. This is not this is rare, but at the same time, if you look at it, serrated adenomas, they secrete a lot of mucin, right? And you wonder whether these serrated adenomas of the appendix are precursors of the mucinous adenocarcinoma that causes the so-called pseudomyxoma peritoniae or whatever. So to answer your question, if I see a lesion and I document that there is a serrated adenoma and biopsy, I always send them for surgery. And one problem that I have when I send them for surgery, and I ask the surgeon, hey, make sure you take a little bit of the base of the cecum also. But the few patients that have followed up, the resection, surgical resection margin was still positive, and the appendix did have serrated adenoma. And when I go back to follow them up to just make sure that there is no tissue left at the resection margin, they were all negative because it's so small, right? So,
Dr. Raj, may I make a comment?
yeah.
So, you mentioned that appendectomy is typically done. My impression was that anytime you're doing a surgery in this kind of situation, it should be cecectomy. Is that overkill for something like this?
So probably, I think it should be what I say is not necessarily appendectomy, but appendix with a little bit of the base of the cecum, right? You need to have a little bit of margin if they can do that. But all the patients that I've sent, they ended up resecting the base of the appendix, but the pathologist kept saying the margin is positive. But when we went back and looked at it, none of the patients that had appendectomy on follow-up showed any residual polyp. As long as they remove, right? Even if they, say for example, even if they remove the appendix and you still have some polyp left, that one should be able to just remove that, right? So.
The second comment I have is, I think we alluded to this discussion. If we were to give this patient an odds, many times they ask this in the clinic, what are the odds that this will become cancer over the next 10 years or next 5 years? I'm sure there's data out there for cis-serrated adenomas. What do you quote to the patient?
I tell them that I don't know. I don't. That's what I tell them. That I say we know that these polyps can go to cancer. If this is a polyp I had, I would get my appendix out without a second thought. That's what I will present. And if you ask me the time and the risk, I don't know. If you also ask the question, how many of us actually go and peep to look at the opening of the appendix? Probably 99% don't do that.
That's agree. May I ask a quick question?
Yeah, please.
If the histology would show a hyperplastic polyp,
Mhm.
what would you do in this case?
I had a couple of patients where there were hyperplastic polyp, and I basically send them to surgery. I deal with all of them as if they're serrated, sessile serrated lesions.
Because it's a large lesion.
Right.
Because it's larger than 1 centimeter, would be
Right.
still
Right.
at risk.
Right.
Okay.
Right. Yeah, I don't know whether what I'm doing is right or wrong, but I'm just seeing these things, and I feel that appendix removal is probably the simplest of all the surgical procedures. And why leave a lesion and let somebody develop something? Although you may argue we don't know whether they'll develop, but we know that serrated epithelial lesions tend to behave differently. And we have also seen appendiceal carcinomas, which produce a lot of mucin. They all have similar features. Yeah.
Right.
This is a tough question, but from the point of surgery point of view, I feel that appendectomy is not that big of a deal, right?
Laparoscopic procedure.
And
I think it depends upon the surgical approach, because in academic centers they may do what we can call an extended appendectomy. In community or in the periphery, when you send somebody like this, I think they're more likely to do more involved resection. And one of the thought on that is they don't know from the serosal side where the polyp ends. When the polyp has an appendix extension into the cecum, even if you tattoo that, they don't know exactly how far out from the appendix to take it out, 1 centimeter, 2 centimeters, regardless of how much you do. And then second, the surgeon doesn't want to go back and have a positive margin. So I think in the cases that I have sent, more than likely my surgeon generally just takes out the cecum. It's a cystectomy is what they call. I mean, they don't do right hemicolectomy, they tell the patient, but it generally ends up to be the major part of the cecum that comes out. So that's where I think the debate changes, that if it's just an appendectomy, it's fine, not a big deal. But if it's a base of the cecum resection, or if this is going to involve the IC valve in anyhow, then, then it basically, the benefit risk ratio becomes, a little bit more discussion into it.
Right. Aman, what you're right. I agree with you. What we are dealing with is these small polyps at the opening of the appendix, not creeping into the cecum. When they creep into the cecum, appendectomy is not going to take care of it. I think then they would probably need either a cecal-based resection, or most of the time, if they're reaching into the cecum, they will end up having a right hemicolectomy if that cannot be removed by endoscopic resection. So these are all.
Remember, the definition of a minor operation is one that someone else gets. Anytime we make a decision, it's a minor operation. That's not necessarily the patient's perspective.
That's right. That's right. Right.
Raju,
Yeah.
are you going to show us the pathology from your biopsies? Or tell us what it is? Okay. So there is no dysplasia in that lesion?
No. This is a sessile serrated adenoma.
Without dysplasia.
Without dysplasia, yeah. And that was the lap appendectomy. that was done. There was a sessile serrated adenoma in the appendix, and there was no cancer. The margin was positive. So that's what I was telling, when we asked, even if I talk to the surgeon and say, hey, this is where it is coming, could you do a section of the base of the cecum with a little bit of rim? They probably do what they normally do. And I brought him back 1 year later, and you can see the staples, and you can see, I don't have a video of this. You can see a little bit of tissue there, and I could not differentiate whether this is serrated adenoma or granulation tissue or whatever, and basically removed the whole thing with a cold biopsy forceps, and then I ablated that, thinking that, okay, if in case this was a margin that was positive, I don't want to leave him with something that he has to deal with again by another trip to endoscopy. And fortunately, this came back as inflammatory changes, foreign body, no neoplasia.
Interesting.
So that's, I wanted to share this to just for the sake of the trainees like, Zubair and others, to just give the impression that, okay, get into the habit of looking not just the cecum from a distance, but also get closer to the appendix and watch. And it's also interesting that Joseph actually shared with me a case where, he also started examining the appendix opening, and he was excited when he saw a serrated lesion that he found.
I do spend about 2 or 3 minutes at the appendiceal orifice nowadays.
Why didn't you share that story, Joseph? I think
Yeah, actually two now. Well, there's and both of them were actually buried in the appendiceal lumen. I generally sort of do, I get really up close, I'll do near focus, and then I'll also do water immersion, and then I'll switch to MBI and just, and sometimes I'll just sit there for a little bit, because sometimes it'll sort of evert, and then things actually emerge from within the lumen. And on 2 separate occasions on 2 separate patients, one was actually, there was nothing there originally. I waited another minute and finally a polyp emerged. In another case, it was a little bit more obvious, but if you just did a sort of, sat far away from the appendiceal orifice and just took a picture of the cecum with AO, that could have been easily missed. And on one case, patient did undergo appendectomy successfully. And then the other case, he had a lot of comorbidities, had cardiac transplant in the past, was on immunosuppression, opted basically for surveillance after an attempted EMR at the appendix. The patient had no any complications after the EMR, and then I actually brought him back after 6 months, and there's so far been no recurrence after sampling from the granulation tissue at the site.
Yeah. I think one take-home message is not only trying to get into the habit of examining the cecum carefully, like Selvi commented on, look at the appendix, look at the base of the cecum, look at the wall that goes to the IC valve. That is an area that one could miss polyps, and also try to examine the cecum a second time with NBI, and document your cecal exam with an appendix opening photograph from a distance, and IC valve, and terminal ileum. So something to keep in mind. And for the sake of trainees, if you see a subtle finding, I think if you don't have the capacity to video record, take lots of photos. It's one thing that you could do to convince everybody by taking photographs of the lesion from different angles, so that it is nobody's guesswork. All right,
Raju, may I ask a quick question?
please.
I recall that the patient had in 2011 two sessile serrated adenomas.
Mhm.
And I was wondering, were there large lesions? Because if he would have five in total, five serrated polyps with two larger than 1 centimeter,
You
he
know,
would qualify for serrated polyposis syndrome.
right,
So,
right. He was actually not yet coming to that group. Those were about 5 to 7 millimeter. They're not big lesions. Actually, when I was trying to prepare for that, I was just looking for that. So, all right.
thanks.
So why don't we request? Let's do one thing. I think it will be a good idea for Zubair to practice summarizing this case. And once Zubair does this, then Sylvia will do the summary as well.
Give feedback, just give feedback. I enjoy to give feedback.
Sure, I can give it a try. So I think the learning points or the summary of this case for me was like first to do the proper like the quality metrics of a good colonoscopy is to like go into the Cecum, do the photo documentation as Dr. Thrumurthy said, and then also like do the photo documentation of ileocecal valve, do the proper examination of the cecum, go into the terminal ileum and taking the picture in the terminal ileum with the villi by injecting water and making the villi prominent, and photo documenting these three landmarks like the appendiceal orifice, ileocecal valve, and terminal ileum. And then in the cecum, like doing some effort to examine the appendiceal orifice and um, with insufflation by injecting some water and then trying to go a little bit into the orifice of the appendix to do the proper examination, so that sometimes the lesion which are at the appendiceal orifice are not missed, and also um, taking advantage of NBI while examining in these areas, specifically like in the appendiceal orifice and in the cecum, because the flat lesions like sessile serrated adenomas can be missed. And then if you see something suspicious, or if you are concerned that there is a lesion there, then taking trying to define the margins and see if it can be removed endoscopically. And if it is not, you are not able to define the margins, if the lesion is extending inside the appendix, then at least taking some good biopsies, and then also taking some good pictures for future reference and for photo documentation. And then taking further steps based on the results of the biopsy, like if it's like a high risk lesion, then referring to surgery for appendicectomy or cecectomy, whatever would be appropriate.
Nicely done, Zubair.
Excellent summary. So
Thank you.
I would just like to add that we should keep in mind that image enhanced endoscopy comprises image enhancement, which needs, of course, as we have discussed many times, high definition scope and monitor and cabling, all of them, and contrast enhancement. So there are two different parts, image enhancement and contrast enhancement. The last one being done with dye-based or equipment-based endoscopy, chromoendoscopy. And in this case, we particularly benefited from the near focus, I think, and water immersion, and especially careful inspection of all these irregular areas, a thick fold, irregular contour of a fold, and the round pits. All these subtle signs helped us to detect the subtle lesion. So that's my take home for today.
Thank you, Sylvia. I really appreciate. Dr. Graham, any thoughts on this case? All right. Any last minute questions? Okay. All right. I want to thank everybody. I want to thank Dr. Graham, Sylvia, Selvi, Ahmad, Ravi, Zubair, Joseph, Sami, Jadish. Thank you so much. I hope you all have a great weekend. Thank you.
Thanks a lot.
Bye-bye.
Bye, everyone.
Thank you.
Sunday.
Bye, everyone.
Bye-bye.
Thanks. Bye.